Good afternoon. Welcome to San Francisco, UC Berkeley Extension's Downtown Center. I want to welcome you to this afternoon's public lecture. And I want to welcome those in the room here today and to those joining us online. You'll hear a public lecture from Sarah Hooper and Dr. Lael Duncan on the End-of-Life Option Act legal and clinical implications. And I might add, this is a topic that clearly has personal implications, I'm sure, for all of us in the future, and if not in the past. So my name's Stan Weisner. I direct the Behavioral Health Sciences programs here at UC Berkeley Extension. We offer a range of programs, workshops, courses in the behavioral health sciences. And today there's special interest for those enrolled in some of our programs that deal with issues, first of loss and grief counseling, which we offer workshops in aging and mental health, and we also have a professional program in health advocacy. We offer CE workshops and end-of-life issues in each of these programs, and some of our instructors are here today who teach in these programs. Joanna Smith, who sits right here, teaches a course, leads the program in health advocacy and teaches a course in this field in the fall. We also have Dr. Mindy Ginn, who teaches in the Aging and Mental Health series, and Dr. David Jill Johnson, who teaches in our Loss and Grief series. And in fact is teaching a workshop later this year on the End-of-Life Option Act, what mental health clinicians need to know. So before I move on, I want to mention that we are fully online today, and it's primarily being listened into by the UCSF, UC Hastings Health Policy and Law Master's Program. Sarah Hooper, one of our speakers, is the lead instructor in that program, and we'll be discussing that program a bit in her own comments. As I said, this program is being live streamed for those in that online master's program and others who couldn't be with us here today. So the session is being recorded and will be posted also on the UC Berkeley Extension website for those who would like to view it later or have colleagues review this session. I want to mention as part of this public lecture series that we offer each year, we have the Dean's Office support, and I want to thank the Dean's Office for supporting this effort. Now, let me introduce our two speakers. Sarah Hooper is the Executive Director of the UCSF UC Hastings Consortium on Law, Science, and Health Policy, and an adjunct professor at UC Hastings College of Law here in San Francisco. Formerly, she worked at the law firm of Leif, Cabraser, Hyman, and Bernstein, a strong supporter of public radio, I should mention. Her research and teaching interests focus on legal issues in aging and dementia care, including healthcare decision-making and informed consent capacity, elder financial abuse, the link between health and access to civil justice, which may be increasingly important in the future in today's political world, and models of interpersonal care. Dr. Lael Duncan is the medical director of consulting services with the Coalition for Compassionate Care of California, an organization dedicated to empowering the people of California to make value-based decisions about their health care needs in times of serious illness and end-of-life issues. Dr. Duncan educates community groups and healthcare providers on end-of-life choices and offers private consulting for families regarding end-of-life choices, hospice, and care planning. She's also a staff physician at the Kentfield Rehabilitation and Specialty Hospital. For several years, I noted she worked as a volunteer for Himalayan Healthcare and spent time working in both Sri Lanka and Nepal. She's board certified in internal medicine, infectious diseases with special interest in advanced care planning and advocacy, palliative care options. I just want to note in her case that part of her bio indicates that she not only does telemark skiing, which is quite strenuous, as well as surfing. So we have a very well-rounded panel here today. Sorry. So we are asking you to hold your questions till the end. There'll be plenty of time. They'll both be speaking through PowerPoints. The slides are available if you want hard copies today. So please welcome Dr. Lael Duncan and Sarah Hooper. Thank you all for attending today.
Hello. Sure, that sounds good. How are we doing? Can we hear me okay? Volume good? Okay. Thank you so much for having us here today. We're really pleased to be here with you all. We're really pleased to also be reaching our HPL students who are watching us via live stream. Our plan for tonight is I'll spend the first half of our time together giving you an overview of the law and some of the issues in implementation. And then Dr. Duncan is going to spend some time talking about the experience in Oregon and Washington, since we have a number of years of experience and data under our belts from those states that will be instructive for California. And she's also going to be talking about, some of the best practices and challenges in having effective communication around these topics. Quick note, this talk does not constitute legal advice, nor does it necessarily represent institutional policy of UCSF Medical Center. I am not counsel for UCSF Medical Center, and I don't represent their policies. So if you have questions or you need advice about a specific situation, I recommend that you consult your institutional counsel and the specific policies at the place that you provide or receive care. And if you provide or receive care at multiple places, you may need to check their policies as they likely vary from setting to setting. Okay, so the California End-of-Life Option Act was enacted by the legislature and signed by the governor in fall of 2015. And in taking this action, California became the 5th state in the nation to legalize physician aid in dying, which is a very specific form of end-of-life care that is strictly defined in the law. The Act permits physicians to prescribe a lethal dose of a drug to a competent, terminally ill patient for the purpose of allowing the patient to end his or her life at the time and manner of his or her choosing. The law allows this prescription only under a very specific set of circumstances, and those circumstances are designed to ensure that patients who request this option are doing so knowingly and voluntarily and have had the opportunity to consider their other options. So I'm going to walk us through some of those details, but I wanted to first make a note about the significance of the law for patients' rights at the end of life. So the law has been heralded by advocates and by some as a major victory for patients seeking greater empowerment and control at the end of life. And it's certainly a significant piece of legislation in California. But particularly in the early implementation, I think that we have reason to temper our expectations somewhat about the impact of this law generally in end-of-life care. And the main reason I say this is that the law does not create a right to aid in dying. It simply allows willing physicians and willing patients the ability to pursue this option without fear of criminal or civil liability. It's a permissive statute, and it creates no affirmative right in the patient. And physicians and healthcare systems have the ability under the law to opt out quite broadly, even declining to provide basic information to patients is something that they can do. So patients who wish to learn about this option or pursue it are reliant on physicians and healthcare systems whose ethics and values around this particular option and end-of-life care generally is usually not transparent to them. So I wanted to make that point. In addition, the law is designed, it's inherently designed to slow patients and physicians down in making this decision. And the idea is that we don't like to think that these prescriptions would be issued incautiously. And so when you combine the legal requirements of the law with existing practical challenges inherent in our very fragmented healthcare system, we are likely to hear of frustrations among patients and family members who are attempting to access this law. And indeed, we already have in the early months of implementation. So for those reasons, I just wanted to sort of make that note that this is a very important piece of legislation, but it is not a right to aid in dying. And for the reasons I've mentioned, there are some legal and practical barriers that may be present for individuals seeking to pursue this option. For that same reason, I find that critics of the law who articulate a fear that it will be used to sort of coerce vulnerable populations into ending their lives prematurely, I also find those claims to be somewhat hyperbolic. So I'm here today to tell you what the law actually is and does, and hopefully we can penetrate through some of the high emotion that tends to come up around this issue. Okay. So the Act makes it very clear that patients and physicians who act within the bounds of the law are engaging in a practice that is legal and that will carry no civil and criminal consequences for the patient or the physician. So the legislature went out of its way to clarify that a patient who ends his or her life using this Act has not committed suicide, and thus physicians who have participated in this option have not assisted in suicide. Suicide still carries very serious civil consequences for patients and their families. That is still true in California. For instance, adverse implications for insurance coverage, for wills, for contracts, for other things. And a physician who assists a patient in suicide in California is still guilty of a felony. So what the law has done is basically carved out this situation in which we say this particular type of patient and this particular physician choosing this option in these circumstances is not suicide. Similarly, euthanasia and mercy killing are also still crimes in the state and are distinguished from aid in dying in that aid in dying requires a competent patient to voluntarily administer the drug to themselves and others. And others, including a physician, are not allowed to administer that drug to them. So that is the difference between aid in dying and euthanasia. So voluntariness and self-administration are the line here. So consistent with those principles, this is how the law has drawn those lines. So only an adult with a terminal illness. A terminal illness is defined as an irreversible or incurable disease in which the patient is likely to die in the next 6 months. That individual must have capacity to make medical decisions and to make this particular decision. The patient must have the ability to self-administer the drug. The patient has to be a California resident and has to be capable of pursuing all the steps in the law. So I like this photo of Jennifer Glass. She was one of the advocates who really helped push for this law. And I like this photo of Jennifer Glass because I find that it's sort of emblematic of the type of person who both designed this law and the law is designed for. And the reason for that is, she's very clearly very ill, but she has this very determined look on her face, right? So the idea behind this law is to empower patients and give them a sense of control. We know from the Oregon and Washington data that this is also the type of person who actually has used the law in those states. So we know that overwhelmingly the patients in Oregon who requested aid in dying under that law were white. They tended to be of higher socioeconomic status. They had insurance coverage. They tended to be from more urban areas. And importantly, last year in Oregon, 92% of them were enrolled in hospice at the time that they took the drug. So the group that tends to utilize this option is not actually, by any measure, a vulnerable population. And so I wanted to share that piece with you. So again, conversely, if the intent of the law is to empower a certain group of individuals, we are also seeking to protect a certain group of individuals. So who are we seeking to protect? Patients lacking mental capacity, so individuals who are not capable of taking voluntary, knowing action are excluded from being able to use this option. Patients who are unable to self-administer the drug at the time that they wish to take it are unable to use this option. And importantly, someone other than patient cannot request this option. The idea is that this must be a request that comes directly from a competent, willing patient to their attending physician. So this means that under the law, even healthcare agents, guardians, and conservators, even if armed with some statement, an advance directive or a living will or a post, that this is what the patient would have wanted, these individuals are not empowered to request this option on behalf of patients. So let's talk about making the request. If a patient wishes to make this request, he or she must make 2 oral requests at least 15 days apart. And they have to make 1 request in writing that needs to be witnessed and signed. So you can see the form that is actually in the law. This is what the patient would need to have witnessed and signed. Again, the requests need to be made directly from the patient to the attending physician without others present, except an interpreter if one is needed. And again, the requirement that these be made to the physician without others present is designed to allow the physician to make a determination that the patient is requesting this and is not subject to coercion or undue influence from other people. And in fact, as part of determining the qualifications of the patient, the attending physician is required to confirm their belief that the patient is not subject to coercion or undue influence. So attending physician responding to this request, and this is something that Dr. Duncan is going to talk about in much more detail, is and should going to be having a very in-depth conversation with the patient. And we can't, if there's nothing else that we come away with today, it's this moment, it's this conversation that is the linchpin of not just this act in particular, but of good end-of-life care generally. So the act contains a long list of counseling and informed consent requirements, so elements that the physician is required to discuss with a patient. So prognosis, diagnosis, alternatives, including hospice, palliative care,